Good day. Our session is about challenges in the outpatient diabetes mellitus management during the pandemic. I'm Dr. Bien Matawaran. I'm an endocrinologist. These are my disclosures, and these are the three objectives given to me by the scientific committee. One is we'll try to discuss the different challenges faced by quarantine patients with diabetes mellitus. Two, we'll discuss the different challenges faced by the physician in managing their patients with diabetes mellitus. And third, we'll discuss the different strategies to overcome the above-mentioned challenges of both physicians and patients. Alongside general COVID-19 guidance to reduce risk, people with diabetes have been advised to aim for tighter glucose control where appropriate and feasible. As you all know, achieving good glycemic control is easier said than done, even under ideal conditions. And because of these challenging times, tight glycemic control is even more of a daunting task. In this study, looking at the impact of different disasters, we see that the duration of lockdown correlates with worsening glycemia. If you look at examples from the Hurricane Katrina, from several earthquakes in Japan, in Kobe, in Hanshin, in the Greater Eastern Japan earthquake and tsunami, and even earthquakes in Marmara and the Gulf War, you see that with the number of days of lockdown, we see worsening of HbA1c among our diabetic patients. In this simulation model, we see that with increasing duration of lockdown, the increment in HbA1c from baseline, okay, to post-disaster HbA1c increases with increasing annual complication rate. So if you look at the predicted diabetes-related complications with the increasing number of lockdown, you see that for both micro and macrovascular complications and even for infections, we see increases in these complications. And this is why all of the challenges here that we see should be addressed, okay, eventually, so that this all will be mitigated as we go through some of the answers to the challenges set, okay, by this COVID-19 pandemic. So we'll go through the first objective. One is to discuss the different challenges faced by our quarantine patients with diabetes mellitus. As you can see here in the slide, there are three important characteristics in these challenges. One is disruption of ambulatory care. There are challenges in medication access and adherence, and of course, social distancing and lifestyle factors. The U.S. Center for Diabetes Control, for Disease Control directive was that all high-risk individuals, including those with traditional cardiovascular risk factors and or established atherosclerotic cardiovascular disease, should stay at home if possible, primarily to limit potential exposure. And of course, this disrupted ambulatory care. We all know that regular follow-up and self-care are the backbone of management of any chronic disease like diabetes mellitus. So that restrictions to routine hospital visits for regular follow-up in the clinic or hospital occurred because of these directives. Patients also postponed their follow-up visits due to fear of getting the virus in the hospital. We see this care model, the impact of COVID-19 with regards to diabetes-related morbidity and mortality. We're basically here already. We saw the effects with regards to diabetes-related deaths and mortality that is not directly related to COVID. So that is represented by the yellow slope, okay? While the orange, okay, graph shows the direct COVID-19 related deaths and hospitalization. So we know that there were disruptions in care, disruptions in both acute and chronic care. So that by this time, so we're now in 2021, we actually will be seeing predictions of greater number of patients suffering from diabetic kidney disease or dialysis, because again, there was disruption in their usual chronic care among chronic care, okay? And also, there could be higher number of patients suffering from diabetic retinopathy, and even predict that there are poorer birth outcomes because patients with gestational diabetes were probably not started timely with regards to controlling blood sugar and insulinization. So again, the impact of that disruption will be forthcoming. How about challenges on medication access and adherence? Okay, so we have to remember that there were challenges with regards to access and adherence to medications. Those at advanced age are sequestered at home. Many of the younger individuals are now newly unemployed and income streams are down, savings have plummeted. So all again would affect medication access and adherence. You have to also take note that supply chains may be threatened, including numerous pharmaceutical ingredients that rely on manufacturers in China. Okay. And of course, we also know that because of the lockdown of different kinds of ECQs, there were limited regular trips to the pharmacy due to restrictions to travel. How about social distancing and lifestyle factors? How this pandemic affected social distancing and lifestyle factors? Okay, social or physical distancing, of course, is the act of deliberately increasing the space between people to avoid spreading an illness. And it is the most important recommendation from the CDC, as well as the DOH, as a community mitigation strategy to limit the spread of COVID-19. However, social distancing does not mean social isolation. Nonetheless, we have to acknowledge the fact that there is increased stress among our patients. There was depression and anxiety in both adults and children. Psychological strain of loneliness can manifest physiologically and exacerbate existing medical conditions. We all know in several studies that those patients at risk are children and teens, people with health conditions, especially prior substance abuse issues, and of course, healthcare professionals and first responders. We also know that stress can trigger unhealthy behaviors such as smoking, dysregulated eating, poor sleep, and reduced activity. And we also know that psychological stressors can worsen glycemic control in patients with diabetes and worsen body weight through increased energy intake. Okay? So with regards to lifestyle implementation for prevention, we see that what was affected was physical activity, nutrition, and tobacco smoking or tobacco cessation. So physical activity because of the stay at home or work at home, advisory and social distancing, physical activity was limited. Nutrition, because of stress, patients relied on unhealthy eating patterns like overeating and emotional eating. There were limited trips to the grocery store. There were decreased access to healthier food items like vegetables, fruits, low-fat dairy, and other perishable products. We chose food items with longer shelf half-life, which are highly processed, and there was increased alcohol consumption and purchase of comfort foods. Tobacco cessation is also affected because we all know that stress may create trigger for smoking relapse and continued smoking behavior, all of which are challenges for our diabetic patients. The International Diabetes Federation came up with some of the challenges of diabetes management in developing countries, which of course parallels that of the Philippines during this pandemic. We see here that admissions to hospitals for diabetic patients are restricted. Hospital requires documentation from the patient to prove a negative COVID-19 test before allowing admission, adding to cost. Access to drugs, especially insulin, is restricted and needs a physician prescription. Again, this was addressed by the Philippine FDA. Low-income patients have less access to recommended preventive measures such as social distancing and use of protective gear. We also know that many outpatient clinics and training units have been closed. Many private clinics of endocrinologists are also temporarily shut down. And due to the fear of illness, patients do not visit a few open laboratories to monitor their blood sugar status, and many do not have a glucometer for self-monitoring. Many patients with diabetes are also elderly and illiterate or have little literacy, and they can't afford to use new smartphones. Even if the cell phone was provided, they would have difficulty utilizing it and require training to do so. So those are the challenges. So what about the different challenges faced by the physicians in managing their patients with diabetes? So I identified 3 of those challenges. One is coping with stress and burnout issues, changes in delivery of healthcare services, and of course, financial difficulties. In the random effects meta-analysis to estimate the prevalence of specific mental health problems, it was noted that anxiety was prevalent in 23.2% and depression at 22.8% of healthcare workers. Women, healthcare workers and nurses had higher rates of affected symptoms. And again, insomnia as a manifestation was prevalent, estimated at 38.9%. So it's very important that this early evidence suggests that a considerable proportion of the healthcare workers experienced mood and sleep disturbances during this outbreak, stressing the need to establish ways to mitigate mental health risks and adjust interventions under pandemic conditions. In a study in Malaysia, particularly in the University Malaya Medical Center, which is the premier university hospital designated as a COVID-19 ward, you see they did a survey identifying hospital anxiety and depression using standard questionnaires to look at, again, anxiety, depression, and positive and negative religious coping. We see that anxiety and depression is prevalent to as much as 36.5 to 29.5% the total hospital or healthcare workers surveyed. And we see that both doctors and nurses are affected with anxiety and depression, as you can see in this table. So burnout prevalence was also analyzed in one of the healthcare among healthcare workers in Malaysia, and we see that again there are personal, work-related, and patient-related burnout, not just for doctors but also for social workers, for laboratory technicians, for hospital food preparation personnel, for physiotherapists. All of us are affected by this COVID-19 infection. And there are specific self-reported causes of burnout in healthcare workers in that particular study in Malaysia, as well as common self-reported symptoms of burnout in healthcare workers. So another challenge among physicians is, of course, changes in delivery of the healthcare system. The mode of communication between healthcare providers and people with diabetes has changed significantly. More prevalent use of telemedicine for the technologically challenged healthcare workers, of course, adds stress to physicians. And of course, there are now physical changes in the clinic. We use PPEs and acrylic barriers, and this, of course, add cost and difficulty in performing face-to-face consultation. And last are financial difficulties. In a survey conducted by members of Medscape, physicians from Medscape and MD Edge, of course, this was done in the United States, more than 17,000 responders across 29 subspecialties or specialties participated in this study. In the survey, they noted that there were income decline, and they associate 92% of those surveyed to COVID-19 pandemic as the cause of their income decline. There were also changes in the average number of patients prior to COVID-19 and presently with regards to the number. And there were less number of patients as well as more number of hours spent now compared to pre-pandemic times. You also have to note that around 44% had permanent reduction in patient volume, although less than 1%. Some of the respondents said that 76% or more patient volume reduction occurred because of the pandemic. So what now are the strategies to overcome the above-mentioned challenges for both physicians and patients? So I have identified some innovations in endocrinology and diabetes management. So of course, we're well familiar with telemedicine, eConsultation, team-based care, and of course, enforcing diabetes self-management to our patients. We have several talks on telemedicine. So this has become a critical strategy to improve access to diabetes care, while simultaneously supporting necessary physical distancing during the pandemic. There's a large body of evidence for the efficacy of traditional telemedicine in diabetes care, showing similar outcomes with traditional office visit. This is one of those studies, although this was done pre-pandemic, looking at initial and follow-up HbA1c levels of telehealth and face-to-face groups. So if you look at the graph on the right, so face-to-face, this is the initial HbA1c, And after follow-up, see a reduction or improvement in HbA1c, likewise seen for those patients who underwent telehealth. Okay, so the drop in HbA1c in the telehealth group was 0.277% points greater than the drop in the face-to-face group. And the percentage of patients with poorly controlled diabetes decreased from 64.4% to 35.6% in telehealth. So that shows you the efficacy of this platform. In the country, physicians either use paid teleconsultation platforms or would use free digital platforms to communicate with their patients. Some would use, again, just Viber or Facebook. For example, in UST, in our clinical division, we made use of a Facebook-based platform pioneered by our chief fellow, Dr. Dong Kabawal. What is good about what we did in the platform is that um, the consultants can participate at real time during the actual chat, okay, consultation. But we have to remember, as based on the National Health Service Advisory, that there are patients that can be seen, okay, virtually, but we also have to forward triage those patients that would need face-to-face consultation and those that may need to be deferred with regards to their appointment. So anyone with new diagnosis of type 1, those who need urgent insulin care, teaching blood glucose monitoring for urgent reason, blood test monitoring, where physical examination is essential, urgent training of other devices, then a face-to-face consultation may be necessary instead of telehealth. So e-consultation may not be as prevalent in the country. So this is a patient-specific asynchronous virtual communication between a specialist and referring provider, typically a primary care that occurs within a shared electronic health record or other secure electronic platform. The benefits of e-consultation across specialties are well documented and include increased access to specialty care, provider satisfaction, and educational benefits for primary care providers. Some have engaged on team-based care. So a variety of team members have specific roles and responsibility for ensuring patients receive optimal diabetes care. It promotes collaborative care that can reduce burnout from clinical care demands. So this can be engaged in the very near future. And last, of course, and most important, is to reinforce diabetes self-management. So this refers to the ongoing process of facilitating the knowledge, skill, and ability necessary to successfully manage disease of their own. It is a critical element of care for all people with diabetes that has been shown to improve patient outcomes. So recommended self-care activities, especially during the pandemic, are as follows. For dietary precautions, we know that dietary intervention with the help of telehealth significantly improves the diet quality, fruit and vegetable consumption, dietary fat, and sodium intake reduction. It was mentioned that you have to address the dietary-related issues through daily or weekly messages, which should be sourced from authentic government and non-governmental organizations. So there are studies showing that when we do that, there will be improvement in outcomes. So ask your patient to prepare food at home by using healthy cooking methods, avoid packaged food, sugary drinks, soft drinks, bread, and ketchups, and keep well hydrated at all times with simple drinking water. So those are just notices that you tell your patients. With regards to physical activity, because of the lockdown, there was restricted exercise, recommended exercise for people with diabetes. So it is preferable to engage in alternative, specific recommended exercises that can be practiced safely inside the home, like aerobic and resistance exercises. You can ask your patient, because of the limitation in outdoor physical activity, to require them to walk on rooftop or lawn of home gardens if available. Use stationary equipments like treadmill and stationary cycling as substitute for running or jogging. Muscle building activities such as weightlifting at least 2 days a week are also advisable for adults. So it is said that sitting is the new smoking. So prolonged sitting should be interrupted by every 30 minutes with a session of light physical activity like stretching of the leg or the hand while at home or in the office. So strengthening physical activity can be performed for 15 minutes a day by using readily available household stuff like, for example, chairs and tables, where they can perform their push-ups, squats, crunches, and even small bags or pouches filled with objects can be used for resistant training and should be done with supervision of family members or only can be performed by adults who are able to do these activities alone. So engaging in more unstructured daily physical activities such as household tasks, gardening, stair climbing, and chair stretching are recommended as part of the whole day approach. And of course, flexibility exercises and balances activities should also be included to improve the range of motion around joints, to improve gait and prevent falls in older adults for 2 to 3 times in a week, for example, by using yoga. So extent to which a person's behavior taking medication following diet or executing lifestyle changes is called adherence. So this corresponds with agreed recommendations from a healthcare provider. So you can ask patients to do pill count, make sure that you prescribe refill with 2 weeks, okay, allocation at least before medication dry up. Inform about the contraindication of medications to prevent the wrongful use of non-prescribed medicine and order medicine from online platform amidst the lockdown. So there are some anti-diabetic medications that are recommended for use depending on the stage or the severity of COVID-19 infection, as you can see in this slide, as well as you have to remember that there are drug-drug interactions with regards to medications given for COVID-19 infection, as well as standard drugs for diabetes mellitus. Self-monitoring of blood glucose and blood pressure is part of diabetes self-care. The International Society of Hypertension came up with guidelines on how to measure and home blood pressure, and the importance of which you can tell your patients to look at this particular website to make sure that their blood pressure monitors are validated. We all know the value of self-blood glucose monitoring. We have recommendations for targets as well as frequency. You tell your patients that online pharmacy is an appropriate solution during this pandemic with regards to finding glucose strips or even digital glucometers or blood pressure monitoring devices. There are a lot of different flash glucose monitoring that's available wherein your patients can actually log in the internet, download their values, and you as physicians can actually look at them. This is one of my patients using that particular glucometer. So that remote monitoring has been present for quite some time with regards to diabetes care. Glucose monitoring is one of those. But there are also healthcare websites and apps that are actually digital one-stop shop, wherein you can monitor, give them targets, and see their reports. So that the opportunities for TeleDiabetology is really a lot, from observation, documentation, and intervention. There could be possibility for therapy adjustments, especially of insulin through TeleDiabetology. The Philippine Society of Endocrinology, Diabetes and Metabolism in their website have several lay advice, okay, especially for insulin titration. You can follow them. Their social media platform in Facebook, Instagram, and Twitter for lay education. So what now are the recommendations for a better new normal for professional societies, healthcare institutions, and healthcare practitioners? So for professional societies, we have to create visual platforms, networks, and in-person meeting opportunities for healthcare practitioners. We have to enhance training opportunities in quality improvement methodologies, leverage professional society relationship to advocate at the government level, and to encourage collaboration of primary care and specialty care professional societies to foster cross-collaborative networks and foster technology, healthcare industry collaboration, and integration of healthcare redesign. For healthcare institutions, we have to incorporate quality improvement and implementation science in methods of routine care, allocate philanthropic funding to promote clinical innovation, provide time for regular practice meetings to discuss innovative solutions to common clinical challenges. Healthcare institutions should foster mentorship of clinicians, enable multidisciplinary collaboration, and encourage beta testing and early stage collaboration with health technology companies. so that delivery of services or non-traditional framework of care can be started. And for us healthcare practitioners, seek virtual training opportunities, search for mentorship and collaboration, understand organizational priorities, and align initiatives by actively approaching administrators, and of course, recruit multiple team members to create a unified voice in advocating for change. So the new normal in diabetes care is now, okay? So that means that usual diabetes care in the future would include virtual visits and home-based care, focus on prevention strategies, medication supply chain guaranteed, and stronger emphasis on social determinants of health. So we have to practice this diabetes care preparedness cycle during the epidemic. So this is characterized by preparedness, response and mitigation, recovery, and surveillance, so that we will not be surprised again in the future. And with that, thank you very much.